So this is heart failure medication. Briefly, we'll talk about what is heart failure. And basically, if this is your heart, it's divided into four segments: right atrium, right ventricle, left atrium, and left ventricle. So blood from the upper extremities come into the right atrium to the superior vena cava. From the lower extremities, inferior vena cava. And this deoxygenated blood go into the right atrium, into the right ventricle. And the lung is somewhere here. And oxygen is added to the blood. And the blood return to the heart, to the left atrium. So this has oxygen. This side, no oxygen, minus oxygen. This oxygenated blood go into the left ventricle and it get pumped out into the aorta and to the rest of the body. Of CHF, basically the heart cannot do its function. So this is a little bit bigger, this side too bigger. Blood stay in the left side, in the left ventricle, and then build up into the left atrium, into the lung. And this is the left heart failure. And mostly we call it pulmonary congestion, vascular congestion. And that's what it is, right heart failure. So there's two types. When you have both right and left symptoms, we call it CHF, so chronic heart failure. And so there's fluid overloaded. The whole thing is we got to get rid of the fluid. And so based on this, we can pick out our medication and see what it does. So we have ARBs, they're doing specific things, and ACE inhibitor. We have diuretic that will get some of the fluid out. We have vasodilator that will prevent decrease preload and afterload. We have the chromotropes that will, so it decrease the rate, and the ionotropes that increase the contractility of the heart so they can do its function. So there's so many medications doing their job. So these are the type of heart medication that you should know for your test. So we will go through each of them and their function, their risk factors, and side effect. So let's begin with digoxin. Digoxin is one they like asking. Most of the time you see a question in it, okay? And so I'll use just a little bit of pathophysiology to see what is going on quickly. So it's an ionotrope. It helps the heart to pump, okay? So that's what you're doing. And then it improves the cardiac output. So it end up improving the cardiac output. But at the same time, it causes, a decrease in heart rate. Okay, it slows down the heart in order for it to reset itself. So it slows down the heart and the time. So it has both what we call chromotropic effect, contractility, and bromotropic effect. So it does so many things. So it's blocking potassium. So when you have low potassium, so hypokalemia, low potassium, the digoxin can bind more and cause problem. And so you should avoid this avoid hypokalemia, because then it increases the toxicity of digoxin. So that's number one, you should avoid it. You should avoid it, okay? And then you should avoid this lichoric acid. This medication also causes low potassium. Like I said, if there's potassium that is low, hypokalemia, digoxin become potentiated, and therefore it binds to more of the potassium side of the distin, and that causes toxicity. You want to avoid that. Because of the way it can bind to the heart and just completely shut it down, you got to check the heart rate, the apical pulse. So check apical pulse for full 1 minute. Just if it's less than 60, don't give them the digoxin. For a child, if the digoxin is less than 70, don't give it to them. And for infant, because of their heart rate is high already, anything less than 90, don't give it to them. And increase your potassium. So increase potassium, because if it's blocking potassium from being pushed inside the cell, there will be more potassium outside the cell. Okay, so it can cause hyperkalemia, toxicity. So anybody on digoxin, you want to make sure their potassium is normal. If calcium is high, you have more calcium inside the cell, and it causes more toxicity. Basically, they read me. It causes it potentiate the effect, so it make the calcium effect more potentiated by the digoxin, and therefore you should make sure the calcium is not too high. One, hypokalemia. If you see it, it will make digoxin toxic. You should avoid high calcium. And 3, you should avoid low magnesium. Because of this, you should avoid calcium channel blocker. Avoid it in patient who is on digoxin. It will potentiate the effect. The hypokalemia, because of this, you should avoid licorice. It's dangerous. It has therapeutic effect, which is very low. Okay, it's 0.5 to 2. You do is the side effect. We're going to talk about the side effect. Okay, the side effect, it can affect a lot of organs. So first, neuro, it causes confusion. The second one that they like to ask is the color change of your eyes. So yellow, green color. You see yellow, green color in your vision, and you should call your doctor right away. That's it. Cardiac arrhythmia, we already talked about the potassium changes. All this is related to potassium, magnesium, and sodium, and a calcium. Usually that's what they like to test is GI symptoms, because GI symptoms is the early sign. So early signs of toxicity. So they usually have like nausea, vomit, abdominal pain, and anorexia. So when you see this in a patient who is taking digoxin, they don't want to eat, they don't want to drink, they have vomit, and they have nausea. That is early signs of toxicity. It's not like you should just call the doctor and then intervene right away. Early signs of digoxin toxicity is from the GI tract. And because it's secreted, excreted by the liver and then kidney, if there's any renal function or liver function, you become toxic. So you should also report that. The most important that you got to pay attention is the GI symptoms. As soon as you see it, that's the early signs of toxicity. Because of that, for children, there's specific instruction, okay? There's specific instruction, and this medication doesn't taste good. So it comes in oral form for kid, in liquid form. Do not, because it doesn't taste good, you'll be tempted to mix it with food. Do not mix with anything. Give it to the kid just like that. And because it's liquid, put it at the back of their throat. If they vomit, or you miss a dose, do not give them another one. However, if they miss 2 doses, yeah, you should call the doctor. Staff need to be watched after giving them the digoxin. So these are, you can see, these are questions they can ask you, SATA question, GI symptoms. One key thing I want you to pay attention is potassium. When somebody have high potassium, we usually give them calcium gluconate to help with that, to prevent the cardiac stabilization. Unfortunately, if somebody is taking digoxin and they have high potassium, don't give them cardiac calcium channel blocker. You shouldn't do that. That will put them in a what do you call a cardiac arrest. So you shouldn't give anybody with hyperkalemia who is on digoxin calcium gluconate. The medication for digoxin toxicity is just to give them antibody, digoxin antibody, and usually they'll give like 5. And then we come to diuretics. The diuretics, there's different types. So you have hydrochlorothiazide and then chlorothalidinone. These two, they are all hydrochlorothiazide group. They are thiazide. So these are thiazide group. And everybody like this. Everybody know hydrochlorothiazide. So, you know, the examiners, they will give you this, chlorothalidone. And that is what you should memorize. Things you need to know is a diuretic, so you get rid of water. But first, I want you to pay attention. This is sulfur drug. So in the question, they can give you, you have to know that this, they won't tell you, but you know this is a sulfur drug. One of the problems with sulfur drug is photosensitivity. So you can teach them to wear a hat, cover themselves, and sunscreen, lotion when they're going outside. So, but they can also develop something we call Stevens-Jones syndrome, which is the severe form of sulfur drug hypersensitivity. So sometimes they will describe a maculopapular rash, a small one on their body, where that is the beginning of massive rash all over their body. That patient is a priority. You want to see it. So if somebody is taking a sulfur drug like thiazide and he described maculopapular rash on the body, a small one, a purple, yeah, you should see this patient. But if you stop the medication, they will go into severe Stevens-Jones syndrome, which they can die from it. Potassium is low, so it causes hypokalemia. And because you lost a lot of water and fluid, where you have hypotension, so usually orthostatic hypotension. So their glucose is high. Calcium level also goes up, so high calcium. So I call it hypergluc. So for thiazide is hypergluc, high glucose, high lipid, so they become hyperlipidemia. The uracil, uric acid goes up, and then calcium also go up. But if somebody is on this medication, look for low potassium. The next one, furosemide, loop diuretics. These are what we call loop diuretics. Everybody know LACEs, which is furosemide. Well, the examiner will give you this. Bumetanide. Sometimes they will give you furosemide. Bumetanide is less common, so that's what most people don't pay attention to. So the same thing. I talk about the sodium-potassium channel in the kidney. So sodium is out, potassium in. Well, this usually bind to the same thing, like loop and of Ellen, we call it. And they bind it, and they let you lose sodium, then water follow. Then that will decrease your blood pressure because of that. So hypotension. It will help with the edema. It also decreases potassium. In effect, there's general loss of sodium, basically. One thing about furosemide, it lasts for 6 hours. When you're giving it IV, okay, it can cause ototoxicity. So basically, it can affect your hearing, so affect nephrotoxicity. Something they can ask you. If you're giving IV too fast, that's when it causes hearing problem. It affects the kidney. Nephrotoxicity is when the dose. So this is dose dependent, and this is rate dependent. So if I'm giving you LACEs, I'm giving it too fast, you should worry for a hearing problem. So they have ototoxicity. So The rate IV form of laces can cause hearing problem, and then the dose can cause kidney problem. Dose of the rate, you should not exceed, okay, 4 grams. So no more than 4 grams every minute. And that's what usually they like to test very much. You drop your potassium, well, you expect them to be hypotensive, is orthostatic hypotension. And then they will have a fluid loss. And so, but that's the main thing you should worry about is low potassium. The next one is the another diuretic, but these are what we call spironolactone. They are the potassium sparing, so they spare potassium. They don't allow you to get rid of the potassium. How does it work? Aldosterone. So there's something we call aldosterone, which usually make you increase your sodium. This is what causes hypertension and get rid of your potassium. Well, guess what? Spironolactone come and say, no, I block you aldosterone. If I block you, well, you cannot increase your sodium and you cannot decrease your potassium. It's the opposite. You decrease your sodium and you increase your potassium. That's how it's used for a CHF. So if your sodium is low, you get rid of your sodium. So water follow. And then you have high potassium. So hyperkalemia. One thing I've known, when they know that this is a common medication, well, they're not going to give it to you. They'll give you something familiar, but you do the same thing. The other name who does the same thing is triamiterene. They are potassium sparing, and there's another one. These are the only medication that doesn't follow the pattern. So triamiterene and epiremine. These are also, when you see it, triamiterene and epiremine, they are all potassium sparing. They spare potassium. So that means they causes hyperkalemia. Moving on. This is my favorite and the complicated one, but I will make it easy for you. So in your body, we have something we call angiotensinogen. So this is the renin-angiotensin 2 system, okay? This is what controls your blood pressure. And you go to the liver, to the kidney, okay? This is made in the liver because it's a protein. And you go to the kidney and renin, there's this renin in the kidney, convert angiotensinogen to angiotensin 1. Then this go to the lung. In the lung, you have ACE, angiotensin converting enzyme, that convert angiotensin 1 to angiotensin 2. The angiotensin 1, the enzyme also, this enzyme convert bradykinin into inactive form. So an inactive form of bradykinin, inactive. So guess what? ACE inhibitor is stubborn. He said, well, I'm blocking you. If I block you, I block you. Before that, angiotensin 2 is a vasoconstrictor. So this is a vasoconstrictor, increase your blood pressure, and it goes and release aldosterone. What will aldosterone do? Well, aldosterone increases your sodium and decreases your potassium. And it's also a vasoconstriction. So this will increase your blood pressure. So this is a renin-angiotensin system. Well, if you give somebody ACE, yeah, the body, it goes here and say, ACE, I'm blocking you. That's why it's called ACE inhibitor. I'm blocking you. If you block this, there is no angiotensin 2. Therefore, you don't have aldosterone. If you don't have aldosterone, well, you cannot get rid of the potassium. and you cannot increase sodium. So what is the things you see with ACE inhibitor? No, sodium is low, sorry. Potassium is high, so hyperkalemia. Hypotension, so that's how you lower your blood pressure. So you get rid of the salt, and that's why it's used for heart failure. Converting of bradykinin to inactive form. Bradykinin is a vasoconstrictor, no, bronchoconstrictor, and stimulates the airway. So there's high level of bradykinin. So this patient have cough, intractable cough, that is non-productive. And the worst effect of bradykinin is angioedema. This is bad. This is airway, and this is another airway. Be sharp. You got to be sharp about this. You got to call the doctor. The cough is a priority patient. And so I've done all the signs and symptoms and side effects using just the mechanism, which is the pathophysiology. Last name of PRR, Lensinoprazole, Enalapril, and Captopril. A pregnant lady should avoid ACE inhibitor. It's a teratogen. In the same family like an ACE inhibitor, and they have last name as sartans. That's how you can recognize them. And if they're going to ask you this question, it will be straightforward. So look at, and then for ACE, it blocked this. Well, ARB said, no, I'm not blocking you. I'm coming all the way to the aldosterone. So they block aldosterone. So they allow this to take effect. They block aldosterone. Therefore, this will happen. So they causes hyponatremia, hyperkalemia. So this is why they call orthostatic hypotension. That's how they can decrease the blood pressure and fluid in a heart failure patient, but they also causes hyperkalemia, cardiac arrhythmia. But they have no cough, no angioedema, because they don't block bradykinin going to inactive form. Taking ACE inhibitor and I'm coughing for heart failure, the cough is not dangerous. It's usually nagging cough and they don't like it. And so you should tell them to stop it and then convert them to ARB. Heart. Now the heart needs to be pumped. It's been failed. You need ionotrope. So dopamine is one of the ionotropes that you can use in addition with the digoxin to help with that. So dopamine is a catecholamine, so it can increase your heart rate. So it's a catecholamine, so it increases cardiac output. Because it's a catecholamine, it can increase your heart rate. Okay, and it can increase your blood pressure too. In a small dose, okay, this is something they like to ask. Small dose, maybe 5 milligrams of dopamine, it can improve your renal function. So the kidney function can improve with that. Okay, so what are the side effects of this? Based on that, this is the side effect. If you give somebody dopamine, you expect their blood pressure to go up and heart rate to go up in a heart failure patient. So you know they don't like it. They'll go into dysrhythmia. So they don't like it. So just know that it's part of the medication we use for heart failure. It's also improve the renal function so that it can pick all the fluid out. So we give a low dose of dopamine. Then we have the vasodilators, okay? I usually call them venodilators because when you say vaso, it means vasodilator means artery and vein. Most of these are usually good at being a venodilator. Basically, it relaxes the smooth muscles in the vein, and if this is the vein, it makes the vein big, so increase the capacity. So increase in the capacity of the vein. And so the vein can keep most of the blood here before and keep it before it goes to the heart. So that decreases the fluid volume of the heart and the burden. Because of that, you should expect side effect. Well, if I'm keeping all my blood in my veins, I will be orthostatic hypotension. When I get up, all of a sudden, I'll get in trouble, right? What do you think the skin will look like? Very warm and flush. So their skin will be warm and flush. What do you think? If you're keeping blood in the peripheral, well, you get headache. You get headache easily with a and so these are some of the symptoms you should pay attention to. These patients, you should be careful not to use cylindrifields because they all do the same thing. They are vasodilators. And so they will do the same thing. They will worsen the orthostatic hypotension. They will increase their headache and flushing. So this is the only one that they like to ask in a severe heart failure. So advanced, this is advanced form of heart failure. Most of the time when the patient is on mirinon, they have decompensated. So when you see a question and they say decompensated, that means advanced heart failure. There's nothing can be done anymore, and they are phosphodiesterase 3 inhibitor. That's how they do their vasodilator. So these patients, pay attention. If you see that, that means they are advanced. You can't do anything because they are advanced. You can only keep the medication for 72 hours, no more than 72 hours. And the medication has to be given by IV, so IV form of it. Okay, you shouldn't keep it for too long, because it's a vasodilator, which is a good venodilator. You got to check their blood pressure. So they have low blood pressure, so the blood pressure can go down. So there's a parameters you should know. If the blood pressure go down below 90, you got to stop it. Or if you drop systolic blood pressure drop more than 20 to 30 points, yeah, that's not good. You need to stop the medication. So if there is on Myrelon IV and his blood pressure is going down below 90, stop, or more than 20 systolic, you should stop. And then somebody will say, why are you giving somebody beta blocker for heart failure patient, man? And their last name is Law. So you have beta blockers are the laws. They have the metoprolol, okay? You have the Cardiology and bisoprolol. So all of them have laws at the last name. Beta blocker to slow everything down, just cool down system, just cool down and decrease the cardiac workload. So it's very important. It's counterintuitive. It decreases the cardiac and it can improve survival. Of course, if patient have an advanced form of heart failure, so you got to look at the question. You always want to pay attention and answer what they ask you. An advanced heart failure, well, you can't give them a beta blocker anymore. Trimethoprim and losartan. This is the end of it. And heart failure medication, and you can use it for any other hypertension topic or cardiac. You can use this. This is the same thing you do for cardiac. So you basically you get both, except some few medications I left it out from the cardiac, like cholesterol medication. But good luck studying. And if you like this, check my website and put the comment over there. All the best of luck.